Hello everyone. In this video, let me tell you about ectopic pregnancy. First of all, the causes of ectopic pregnancy. The maximum risk is always high with prior tubal surgery. If in previous pregnancy, the woman had undergone salpingostomy for ectopic pregnancy, then the chances is high of getting ectopic pregnancy in her second pregnancy. So the maximum risk is always with prior tubal surgery, but the most common cause is different, which is pelvic inflammatory disease. The organisms causing PID are chlamydia and gonorrhea. Next, let me tell you about the hormonal parameters in ectopic pregnancy. In normal pregnancy, beta HCG and progesterone levels are high, but in ectopic, both decreases. So, pregnancy can't be maintained and it shuts off. Next, there are certain types of ectopic pregnancy. The first is abdominal, cervical, and ovarian. There are certain criteria to diagnose these types of ectopic pregnancy. For abdominal, the criteria is study for. For cervical, it is cerebral. For ovarian, it is fecal bump. Small trick to remember this is abdominal has DNA, study for us DNA. And ovarian is like ovum, goes with sperm, which is fecal bump. And the remaining ruben is for cervical. Now, let me tell you about the sites of ectopic pregnancy. The most common site is ampulla, then isthmus, then fimbriae, then interstitium. There is a question that in which site the ectopic pregnancy ruptures later, that is interstitial stage. Ruptures later. Let me tell you how to diagnose ectopic pregnancy. For diagnosing ectopic pregnancy, there is a one classical triad which is seen in approximately 50% of the patients. That is UPT positive 6 to 8 weeks back. Amenorrhea for 6 to 8 weeks. Now presented with abdominal pain and spotting. This triad is seen only in 50% of the cases. In such cases, when pregnant woman presents with such symptoms, then we have to do transvaginal ultrasound, which is the investigation of choice. In transvaginal ultrasound, if you do not see gestational sac and you see adnexal mass, then it is ectopic. If you see fluid in pouch of tubercle, then it might be ruptured ectopic pregnancy. Ruptured ectopic pregnancy has different management that I'll tell you later. In another case scenario where you do not see gestational sac, but you do not see adnexal mass also, then you have to do serum beta HCG test. And serum beta HCG, if the value is less than 1500 international unit per liter or 1500 to 2000 international units per liter, then you repeat it after 48 hours. Why only 48 hours? That is 2 days. Because in normal pregnancy, beta HCG doubles after every 48 hours. But in ectopic pregnancy, this doubling time is increased. Doubling time is increased. It may take more than 48 hours, like 48 to 72 hours, or more than 72 hours. So, the prolonged doubling time is characteristic of ectopic pregnancy. After 48 hours, you did ectopic serum beta HCG and you noticed that beta HCG has increased, but it is less than the doubled value. Then it is ectopic pregnancy. Beta HCG has increased but doubled. Then it is normal intrauterine pregnancy. Then why didn't you see the gestational sac on TVS? Because it is early pregnancy. But if you observe beta HCG has decreased, then it is failing abortion. I mean failing pregnancy, which is abortion. But beta HCG is more than 2000 international unit per liter. This is the case only when beta HCG is less than 1500 or 1500 to 2000. You just repeat the beta HCG after 48 hours, keeping the concept doubling time. But when it is more than 2000 international unit per liter, then no need of serum, need of anything, just it confirms ectopic. So now we have to decide what management you have to do. In cases of stable patient, two types of management, conservative and medical management. Conservative is given when beta HCG is less than 1500 international unit per liter and the patient should be stable, and the beta HCG level should be falling after every 48 hours. Then this is managed conservatively. No need to do anything because it resolves spontaneously. But in medical management, is done with the methotrexate when beta HCG is less than 5000 international unit per liter. Stable, but beta HCGs are not falling like this. But it is less than 5000 international unit per liter. Then you have to go with the methotrexate. And there should be no fetal cardiac activity. The gestational sac size should be less than 4 centimeter. No signs of rupture. No fluid in pouch of Douglas. And the patient should be stable. Then you can go with the methotrexate management. In methotrexate, there is a single dose protocol and multi-dose. In single dose, 50 mg per meter square IM is given on day 0, 4, 7. Actually, on day 0, you give first dose of methotrexate plus 50 mg per meter square IM. On day 4, you check beta HCG levels. If the beta HCG levels had fallen more than or equal to 15%, then no need of second dose. You just follow the case with beta HCG monitoring. Then every weekly till you get less than 10 international unit per liter, every weekly once beta HCG monitoring is done. That is enough. But beta HCG has not fallen more than 15, but it has fallen less than 15% only. Then second dose should be given on day 7. The same 50 mg per meter square methotrexate is given. In multi-dose protocol, methotrexate 1 mg per kg on day 0, 1, 3, 5, 7. These doses are not important. Just medical management conditions they'll ask you. Just for uh, remembrance and telling you 0, 1, 3, 5, 7. Whenever you're taking methotrexate, you should not use any shade, shouldn't expose to sunlight, and no sexual intercourse. This is about the medical management. And in cases of unstable, where you see SPB less than 90, tachycardia, and fluid in pouch of Douglas, bleeding, unstable patient, then you do surgery. In surgery, salpingostomy or salpingectomy is done. If patient desires future pregnancy, then salpingostomy is done. If family is completed, salpingectomy is done. After surgery, anti-D is to be given. If the surgery has happened less than 12 weeks, then 50 microgram is enough. If it has happened more than 12 weeks, then 300 micrograms to be given. This is about the surgical management. Actually, this is a ruptured ectopic pregnancy is an emergency case. So you have to first stabilize the patient with the two wide IV cannulas, give her IV fluid, And the definitive management is surgery. Salpingectomy or salpingectomy. And for exam purposes, there are certain signs in ectopic pregnancy. This is on transvaginal ultrasound. If you see this bagel sign, this is called bagel or tubal ring sign. It's a characteristic of ectopic pregnancy. This is also tubal ring or bagel sign. And on color Doppler, you see ring of fire sign. I'll show you the ring of fire sign. This is ring of fire sign, which is characteristic of ectopic pregnancy. This is all about ectopic pregnancy. Thank you.